do bypass surgery. There are certain, most of us, in America they say that I was in Seattle some time back, and they say 30% of our work is taken by cardiologists now, which is true, which is the case in Singapore too, and all over the world. But as these people grow older, there are more people getting older and older, there will be more repeat revascularization, either in the form of repeat bypass surgery, for example. Repeat bypass surgery is a very difficult problem because there will be a lot of scar tissues and so on. They can do it once. They cannot repeat 3-4 times, but we can go in. Similarly, repeat angioplasty also, there is a limit. Sometimes the left vein, which is very short or split or something, sometimes you have to do bypass. So it is a symbiotic relationship or a combination or a sort of a, with the cardiothoracic surgeons and the cardiologists. And as we showed you all these new techniques, not everybody knows how to do all these new techniques, but they are very important. The advances are very, very much more than what it used to be. For example, when Andreas Grunzig did the first angioplasty about 36 years ago, I was with that team at the moment, we had a non-steerable balloon, but it was in infancy. Now the stents and the balloons have grown up, matured, different techniques. Similarly, surgery also has grown up. It's not that just cutting and putting, they have off-pump bypass surgery, on-pump bypass surgery. They have a minimally invasive cardiothoracic surgery even for bypass. So there are many things which can do together. I hope, Dr. Lee, that answers your question.
Oh yeah, I feel sorry for my friends.
I think just as a quick add-on, one of the things about repeat revascularization is now with the advent of the bioabsorbable stent, it dissolves after 2 years, and all it leaves is a small trace of 2 metal markers. The CT scan that was shown earlier just shows 2 small bright spots. I don't know if you noticed that. And that's all you have at the end of it. So now the option of restenting the same area several years over the next 20, 30 years is not an issue anymore, so you can keep reimplanting stents that then dissolve. You only need the vascular scaffold for 6 months. After 6 months, it starts to dissolve. By 2 years, it disappears. So repeat procedures are easier. Surgeons don't like doing a second bypass procedure on a patient as well because there's a lot of scar tissue. At that point, they usually refer a patient on for stenting. Now, there was an article in the New England Journal. It was called "A Heart with 64 Stents." This poor patient was from India and had 64 stents implanted over the course of something like 20 years. They were all metal stents. With the advent of the new technology that you've just seen, if you really needed to have something like that done, you wouldn't have 64 stents inside you, they would all disappear. Having said that, it calls into question why anybody really needs 64 stents over 20 years. The transradial approach has made it easier. Our patients are ambulant and out straight away. You can do transradial, angiogram, angioplasty, staged angioplasty, all within a few days, and the patient has very little discomfort. So these are the new advances, but as you had mentioned earlier, with bypass surgery, nowadays they're minimally invasive techniques to get in as well.
It's just like your so-called gamma knife has gone to computer-assisted brain surgery. I mean, the terms changes, you know. When I heard first time long ago gamma knife, I was thinking, wow, fantastic, but now got more techniques in neurosurgery. So similarly, we also have different techniques. Any other questions? Comment? You are allowed to comment also, you know, your own experience, for example. Otherwise, I'll show you some more slides to keep it up to 2 o'clock.
Any more questions?
If not, I will show you some more slides. See, because, you know, since you are here, came all the way, that's nothing, blank. Okay, ad hoc angioplasty, meaning we do sometimes angioplasty, patient come, we do angiogram, angioplasty, all one shot. In private sector, ad hoc angioplasty is done. The reason being that when you do 2 times, the patient has to pay twice, and he has to be admitted twice. So it's an inconvenience as well as time. And 80% of angioplasties in the same session as diagnostic angiogram in many cath labs worldwide. Majority emergency of primary angioplasty. Primary means first time, or first angioplasty straight away. Angioplasty in the first decade, balloon only plain, we call it plain old balloon angioplasty. Some people call it old lady, sorry for that. 4 bar. But 3 to 5% of the time, the patient had to go for emergency surgery those days, which was a traumatic ending to what was supposed to be a minimally invasive procedure. Debate, I've already talked to you about that. Discussion, yes. This is the guy, you must know. Andreas Grunzig. This is the guy who first did the angioplasty in the world. I saw him and he gave me a motorbike ride in San Francisco last time. I was very scared because to sit as a pillion rider is not a joke. I was very scared. But he, at the age of 36, died in a helicopter crash. But that did not stop anything. He was a radiologist actually. And you see, when you look into the history of angiogram per se, the first angiogram was done by a medical student, not by a doctor. He was a fourth year medical student in Germany. He one day thought, why not find out the coronary artery? So he put a urinary catheter. He did his own cut down in the vein, vein or artery, whatever it is, he pushed through, I think it was a vein, went through and he put into the heart and went to the X-ray department and took an X-ray. So that was the first angiogram done in the world. What was the result? The professor sacked him. His medical career was stopped. So what? But he is a genius. At a later stage, I understand that he was given Nobel Prize or something, even though he was sacked. So sometimes things are done accidentally too. Now coming to this, just by the way, for your entertainment, dream of intervention is fulfilled. That is my word. PCI provides more rapid symptomatic relief, appropriate for high-risk patients with poor symptom control. It does not improve long-term survival or prevent AMI in low-risk patients, but in high-risk patients, it improves lifespan also. PCI, of course, will not replace optimal medical therapy for stabilization of atherosclerosis. PCI will not relieve angina when there is no angina. Of course, it will relieve only when there is angina. PCI is highly effective to relieve flow-limiting stenosis or occlusions, restoration of perfusion, and symptom relief. There is dramatic advances in the interventional cardiology for the last 36 years. I put here 36 years, from steerable guide wire to drug-eluting stents, provide non-surgical solution to angina pectoris. Now I will show you some interesting pictures which I know you have seen it before. This patient is a postpartum, she developed chest pain. You can see the angiogram here. Can you see ST elevation? Acute infarction after delivery. And this patient had what is known as dissection, spontaneous dissection of the coronary artery, and that was fixed by angioplasty. Not by me, but it was done in one of the centers. So this is the spontaneous dissection. Sometimes you do get in coronary arteries. These are all very rare. This is the fractional flow wire I'm showing you, and this is how the monitor looks like, FFR. Syntax, all I won't go into detail. This is a patient, very interesting. Can you see a normal artery here? This is a normal, but these are all not at all normal. This is called coronary artery aneurysm. Very rare, we do find in some people. The commonest cause is atherosclerosis, Kawasaki disease, coronary catheterization, occasionally, and congenital. But this particular case, nothing. It is ulcerative colitis, so inflammatory disorder. All right, these are all very, very extremely rare in the world. This is just to show you, we were in the paper some time back, heart disease, a lethal group, and they pictured both Dinesh and myself in the Straits Times. This is what we do in the femoral artery. This is in Mount Elizabeth Hospital in one of the demonstrations. This is what we do in the femoral artery. This was long ago. See the difference? They and me, my hair gone lesser now. You can't even hear hair. Next, this is through the hand. You do the radial artery, and of course, risk scoring system. We have something called TIMI and the great risk scoring system. We sometimes do, and of course, we also look into Killit classification. These are the fraction flow rates. Those who are interested in reading, you can read New England Journal of Medicine. And this is the one I showed you, one picture where LAD was completely blocked. Then we put a stent wiring, put a balloon, and then put a stenting, and the artery is perfectly all right. So PCI is a great benefit for revascularization. Ischemic area was reduced with PCI. Courage trial was grossly underpowered according to them. So now we know that the PCI again is going up. This is one of those survey done long ago that in stable coronary arteries, medical therapy is mostly used. PCI only 7% and bypass surgery 2%. This is stable coronary artery. But unstable coronary artery, you have to do interventional therapy. These are our statistics, which I think you don't need to go. Now you can ask more questions. Dinesh will answer also.